Good afternoon, microbiology. Today we're going to be talking about immune disorders. So these are disorders associated with the immune system. Just to recap, for our immune system, remember we divided it into innate immunity and adaptive immunity. That adaptive immunity is specific to the particular antigen or pathogen that we're dealing with. The innate immunity are these general defenses that we have, and they're going to be immediate. The adaptive immunity will see a lag because these specific antibodies will have to be made, particular cells will have to be activated to be able to take care of these antigens, whereas innate immunity is more general and more immediate. So we have hypersensitivity or allergies to particular antigens. An allergen, we say an allergen is the antigen that causes the reaction, or what we call an allergic reaction. So the immune system, when we're talking about hypersensitivity, can react to a harmless substance as if it were something that's harmful. So something that is harmless, such as peanuts, now becomes a life-threatening substance that could kill someone if they go into anaphylaxis, for example. So there are four types of hypersensitivity reactions. We have type 1, which is anaphylaxis, type 2, which is cytotoxic, type 3, which is immune complex, type 4, which is cell mediated. So for types 1, 2, and 3, these are going to be immediate reactions. They're within minutes, or up to a day within the day, and those are going to involve antibodies. When you get to type 4, that involves a more delayed reaction, and that's going to involve T cells. T cells, those are just a type of white blood cell that we've previously discussed, or a type of lymphocyte as they're called. And the other lymphocytes would be, B cells and your natural killer cells. The B cells produce antibodies. The T cells, they destroy these infected and even cancerous cells. Natural killer cells are also going to be a part of that, and we call those NK cells. And they kill viruses, or cells that are infected with viruses and cancer cells, but they do it without the use of antibodies. They're able to just recognize when a cell is abnormal because they notice that it lacks these MHC complexes on their cell surfaces. They've been downregulated in these infected cells, and they'll target them for destruction. So they're very effective and fast-acting. So for type 1, we call that anaphylaxis, and this is the most common type, and I'm sure you've heard of it before. And it involves the formation of IgE antibodies. And if you remember in that acronym we memorized in the last lecture, these are involved in allergies, and you enunciate the E there to remember this antibody's purpose. It's going to occur in two stages. You have this first exposure where you don't really have any type of major reaction. They call that sensitization. You get sensitized to it in that exposure, but it doesn't cause this major reaction. It's the subsequent exposure, and we call this the subsequent response, when you're re-exposed to that allergen, and now you've already been sensitized to it, and you have this release of histamines, and that's going to cause three effects. Number one, you're going to have an increase in dilation, and the permeability of the blood vessels is going to increase, and that leads to swelling and redness. Then you're going to have an increase in the secretion of mucus, so you'll start to have a runny nose. And then the stimulation of smooth muscle contractions, and that leads to the constriction of your bronchioles. So you'll see difficulty breathing, runny nose, inflammation. We have two types for anaphylaxis. We have what's called localized, and then one that's called systemic. So if we're talking about localized, this means local. So this is going to occur in particular areas. So if you inhale the allergen or you ingest it, you might have hay fever, asthma, food allergies, or atopic dermatitis. And atopic dermatitis, that's what you probably never heard that before, but what that means is eczema. So that's a chronic inflammatory skin condition where the skin becomes itchy, dry, and inflamed due to the exposure to these allergens. So you can treat it with antihistamines, and that blocks histamine receptor sites, which is going to prevent the symptoms. They also call that atopy. You'll notice, like, both of my kids, when they were really young, which they are still really young, but when they were like just a few months old, they had eczema. but then it went away as they grew. And that happens a lot of times with infants because their skin barrier is still developing. So it's soft, it's more fragile. So allergens and any kind of irritant can penetrate that skin barrier more easily and cause those inflammatory responses. Now, it doesn't always go away. Some people have a genetic predisposition to eczema and they'll have flare ups forever for the rest of their life. And that could be genetic. So then we have systemic. So this is the most common when allergen enters the bloodstream. So it goes into the entire system. So for example, if someone is allergic to penicillin and they get an injection, well, then you could have a systemic reaction to that, anaphylaxis. Bee sting goes right into your bloodstream. It could be a systemic reaction. So these affect the entire body, and they can be extremely dangerous. If you're really allergic to a bee sting, you could be dead in 20 minutes. So that's why you have the EpiPens, and so we treat these systemic anaphylaxis with EpiPens, which contains epinephrine, which is why they're called EpiPens. Now, for some molecules, they're actually so small that they don't actually trigger an immune response by themselves, but they can form a complex with larger molecules in our bodies that then cause them to become or cause us to have an allergic reaction to them. So, for example, with penicillin, penicillin is super tiny that it doesn't cause a response, but in some people, when it binds to proteins, it forms a complex that they are allergic to. Now, the first time they're exposed to that, it'll be sensitization and they won't have a reaction. But the re-exposure, the second time they get penicillin, it could be extremely dangerous. It could be life-threatening because it goes through their entire system if it was some type of injection. So for anaphylactic reaction, what are some things we're going to be checking for? Their airway, their breathing, circulation, and then if it affects their mobility, and what was the exposure? To what level were they exposed? So diagnosis, you're looking for acute onset of illness. Did this happen quickly? Are they able to breathe? Is there circulation issues? And have we seen any changes in their skin? So what you're going to do with this is you're going to want to, of course, call for help. But what they recommend that you do is lie the patient flat and raise their legs up. And what you're trying to do is restore blood flow to their core. So you want their brain and their heart to be getting plenty of blood so that they have enough oxygen to continue to work. So here are some symptoms of these allergic reactions. I remember when I was in college and after I just got married, we were renting this really cheap house in Jacksonville and we were living in a basement. And I was down there always studying and doing my homework and stuff for classes like microbiology. And my face, like my lips and around my cheek would swell up randomly every now and then. And I never really looked into it. But now looking back, I think it was some type of, chemical exposure down there, allergic reaction that I was having. I'm not sure what it was, but there was definitely something down there that I was having a reaction to. So that was all type 1. So for type 2, we call these the cytotoxic reactions. They're caused by antibodies reacting to antigens attached to cells. So the antibodies are reacting to these cell surface antigens that are presenting themselves on these foreign particles. So of course the macrophage would recognize that for destruction. So we see neutrophils involved in this, and neutrophils do engulf and they destroy pathogens through that phagocytosis. Interestingly, for them, they're granulocytes, so they can actually release these granules, these antimicrobial substances that will also target these cells for destruction. So it says that occurs when the incorrect blood type is transfused. So if you transfuse the wrong blood type, well, if they're blood type A and they get blood type B transfusion, that's going to be a massive reaction because they're getting all of these molecules that have a different cell surface protein, which is an antigen, and now your immune system is going to be targeting that. So someone could easily die from a wrong blood transfusion. You also see this when Rh negative moms give birth to Rh positive children. So the reason that reaction happens with mothers and their babies is you might actually not see it the first time. But the Rh factor is a protein on those red blood cells, So if you're Rh negative, then you don't have that. So your system is going to recognize Rh positive blood as a foreign, as an antigen. So during the first pregnancy, that's where that sensitization occurs with that Rh positive baby. So they might not have a strong reaction and it won't harm the child. But after delivery, her body is going to start making antibodies against the Rh positive blood. So in her next pregnancy, if she has an Rh positive baby, her newly formed anti-Rh antibodies are going to cross the placenta and could attack the baby's red blood cells because now they're seen as foreign, and then that could lead to a cytotoxic immune reaction. And what's the good news is that can be prevented if they give them a shot of something called RhoGAM during her first Rh positive pregnancy, and that blocks the immune response. So her body will not make those harmful antibodies for her next pregnancy. For type 3, we have what's called the immune complex reaction. So this occurs when insoluble antigen-antibody complexes cannot be cleared from the body. So they start to build up in different places. So you get these clumps that are trapped in our tissues, and they activate the complement branch of the immune system, and that's going to result in intense inflammatory reactions. So that damages our organs and whatever parts of the body have these clumps in there. So one common result of this is something called farmer's luck. If they inhale too much hay that has mold spores in it, or it could also cause rheumatoid arthritis. So type 4, this is cell mediated, and this is going to take longer. So it takes about 12 to 72 hours after exposure for these symptoms to appear. A common example of this is poison ivy, and they call that contact dermatitis. So you get those plant oils on your skin, but then it takes a while. You might not see that start to pop up until the next day. Now, what you can do with poison ivy is if you know you've been exposed, and I've done this several times, like doing yard work and you cut a bunch of grass, or maybe you were sling blading near the woods and you touched some poison ivy, is immediately go wash your skin off with soap. Get a shower, use lots of soap to try to get those oils off so that it doesn't result in either as much contact dermatitis or any at all. So the allergens attach to the body cells, and the T cells think they are foreign, and they attack the body cells that the allergens are attached to. So then you get those symptoms on your skin from contact dermatitis, for example. And this is the same way that they actually do those skin tests for tuberculosis. So if they have tuberculosis, then their cells are sensitized to it. So then when they're exposed to that little injection of tuberculin, they have the reaction and the rash pops up if they already have tuberculosis. It's not super accurate, and it's not even the primary way that they test for it, but it is a way that you can test for it. So some autoimmune diseases that occur when the immune system loses tolerance. And tolerance is the ability to distinguish ourself, what is ours, from what is not. So we have an ability to do that, and that develops before we're even born. So there are 4 types of autoimmune diseases. Type 1 would be autoimmunity. So this involves antibodies that attack our self cells that have been infected with a virus. An example of that is hepatitis. So because our liver cells have been infected with that virus, our immune system does not recognize them as self and tries to attack them, and we get the symptoms of hepatitis and liver damage. Type 2, cytotoxic autoimmune diseases. So this would be Graves' disease, myasthenia gravis. And for those, remember Graves' disease, that leads to an overactive thyroid, and we'll look at that in a minute, hyperthyroidism. And then myasthenia, or what's abbreviated MG, is a neuromuscular disorder. And we'll look at that here in a second. But again, this is the immune system attacking different parts of our body. And in that scenario, it's the neuromuscular junction. So that communication gets damaged. And we'll look at some symptoms of that here in just a minute. Type 3, immune complex autoimmune diseases, including systemic lupus erythematosus and rheumatoid arthritis. You've probably heard of lupus before. We'll look at those. And type 4, cell-mediated autoimmune diseases such as diabetes mellitus and multiple sclerosis, or MS. And you've probably heard of lots of these, actually. So the treatments for these diseases, because they're autoimmune, is using drugs that suppress the immune system. And a lot of these drugs actually work really well to alleviate the symptoms of these diseases, but because they suppress the immune system, they make you more likely to get other types of infections and diseases. So a good way to think about autoimmune problems would be, for example, with hepatitis. Normally, your immune cells are only attacking foreign substances, and your own cells are able to stay healthy and protected. But with autoimmune disorders, your immune cells are now attacking your own cells, and you end up with damage to your body. For example, with hepatitis, now they're attacking your liver cells, so then you have damage to your liver. So this is Graves' disease. You'll see it leads to this really enlarged thyroid, and then you get what's called hyperthyroidism, and then you start to produce certain hormones at too high or too low of a level because now it's been swollen. And basically what you end up with, the thyroid producing too much thyroid hormone, which completely dismantles the balance of your metabolism. Myasthenia gravis, this is where it actually attacks receptors at the neuromuscular junction, in which case that communication is going to be decreased. So what you're going to see here with people who have MG is they're going to have muscle weakness. And that's going to be weakness in their voluntary muscles because this is what they would be able to control normally. So it could cause problems with their facial expressions. They might have kind of like half their face is kind of like saggy and droopy and they not able to smile like they used to. Their chewing can be inhibited, their breathing, their limb movement, etc. And then also, of course, you're going to see fatigue because that connection is weakened. For lupus, or systemic lupus erythematosus, this is a chronic autoimmune disease where the body's immune system mistakenly attacks healthy tissues and organs, and this can be throughout the body. So the severity of this just depends on where all it's causing inflammation and damage. It could be skin, joints, kidneys, even the brain, any organs really. And then rheumatoid arthritis is where you have the immune system attacking the joints. So you get pain, swelling, and stiffness in the joints. For type 1 diabetes, the immune system attacks the insulin-producing cells, or what we call beta cells, that are in the pancreas. So that destruction leads to the body being unable to produce insulin. And that hormone, of course, is necessary for regulating our blood sugar levels. So the exact cause of this actually isn't exactly known, but I think it's either genetic or environmental or probably both that are playing a role in that. And then MS, or multiple sclerosis, this is when the immune system attacks the myelin sheaths around the neurons. So that causes damage and inflammation of the neural tissue. It can become so damaged that it forms scar tissue, and that's why they call it sclerosis for scar tissue, or sometimes they'll call them plaques. And again, all of these are going to vary in their extent of damage, just depending on how much damage has occurred, how long have they had this condition developing. So for MS, you might see numbness, tingling, and pain in certain areas, muscle weakness, stiffness, might have weird like muscle spasms. They might become unbalanced and they'll lose coordination. And there are, just like the rest of these, immune suppressing drugs that you can take. And there's a lot of newer, very expensive treatments for multiple sclerosis. So with this, we think about, our tolerance, how we're able to distinguish self from non-self. Well, when people get transplants, it's not going to be perfectly, consistent with our self. So our immune system will often recognize them as non-self and try to reject those transplants. So in order to alleviate that problem, they try to do what's called tissue typing, where they make these MHC, these major histocompatibility complexes. They try to match those to our own so that our own body doesn't recognize it as non-self. So privileged sites would be those sites in the body that do not have antibodies normally circulating, and that would be the cornea and the brain. So if you were to do a transplant there, then you wouldn't have this issue really, except that, for example, with the brain, we're not doing brain transplants, so it doesn't really matter in that sense. So what are some types of transplants that we have? Well, we have autograft. Auto means self. So this would be when you take something from the person's own body and move it somewhere else. For example, a skin graft. Isograft would be if you have an identical twin. So their genetics are exactly identical to you, and you take some of their tissue and you transplant it to their twin. So, for example, a kidney transplant from two twins is going to be perfectly compatible because their DNA is exactly the same. Allograft, this would be a part from another patient that is transplanted to them, but you would have to do that tissue typing and hope, or ideally, their MHCs are somewhat close in the individual that you're transplanting from. And then we have the xenograft, which would be a part from another species is transplanted into a different species. And typically what you see with this is pig valves being transplanted to humans, which is pretty amazing. Here's one of those pig valves, heart valves up here on the top left. So usually for that, they'll actually use those to replace human aortic valves and mitral valves. So it is compatible with our hearts. They're actually pretty similar. The only issue is they don't last as long as mechanical valves. If you give someone a mechanical valve as a replacement, these pig valves will only last maximum about 15 years. Now they work really well, and you actually don't have to take blood thinners if you actually get a pig valve in your heart. The only issue is they don't last as long as a mechanical valve, so you'll actually see them wear out. So if they're going to use, and especially with elderly people who may, they're already taking a lot of medications, you don't want to have to give them a mechanical valve, and then they're having to take blood thinners for that, and that might inhibit other drugs they're taking. So with pig valves, usually they're using those in older patients because they only last about 15 years. So if the person, may not live only 8 more years, then this would be a better option than a mechanical valve. So some immunodeficiency disorders, these would be a lack of a sufficient immune response. So we have congenital immune deficiency, which would mean from birth. This would include antibody deficiencies. So the antibodies, there aren't enough or they're not there at all. Cell-mediated deficiencies, so a lack of T cells, or you could have a deficiency of both antibodies and these cell-mediated immunities. If it's acquired, that means it develops throughout your lifetime. That could be caused by malnutrition, cancer, certain kind of treatments, and even viruses. And the most common example of this would be AIDS. So AIDS is caused initially, and the development of, a virus in our body that we could be infected with called HIV. So HIV is just an RNA, what they call a retrovirus. So because it's based on RNA, when it infects our bodies, that RNA has to be turned back into DNA or used as a template to make DNA. They call that reverse transcription. And that's why they call this a retrovirus, because it goes backwards from what you normally would expect in the central dogma from DNA to RNA to protein. The enzyme that takes care of that is reverse transcriptase. Ends in ASE. We have an enzyme there that's going to help it move from RNA to DNA. And just those letters, HIV, it stands for human immunodeficiency virus. So just to kind of look at the pathway of what HIV will do, when it enters the body, it's going to infect T cells, specifically CD4 plus cells, which are helper T cells. So these cells help coordinate immune responses. HIV uses the CD4 cells to reproduce. So it starts to take over the cell's machinery and it makes more copies of itself. When it does this, it actually destroys the CD4 cells. So one symptom of HIV exposure is going to be a decrease in the number of CD4 cells in their bodies. So as more and more of these cells are destroyed, the immune system gets weaker and weaker, and the disease develops further and further. Which means if you're losing these CD4 cells that help you facilitate immune responses, your immune responses or your immune system in general is going to get weaker over time. So eventually, it progresses to AIDS, and we call that acquired immunodeficiency syndrome. This is developed over time. And where they kind of have that where they do have the definition of in that marker for, okay, now this was HIV, now we're going to call it AIDS, is when the CD4 count falls below 200 cells per cubic millimeter. So if that happens, then we say they have AIDS, and then at that point, they're really susceptible to opportunistic pathogens. So at that point, once someone has AIDS, the simplest little illness that a normal person who has a normal functioning immune system would be able to handle could kill them, which is super sad. So here's just a little picture showing that the HIV virus destroying a white blood cell. Because that's really what, if you're going to just summarize it, that's what it's coming down to. And of course, that's going to damage your immune system. So looking at kind of how they do the stages here before they classify it as AIDS, of course, you would look at the percentage of CD4 cells would be kind of a more numerical way to do it. But then they also look at weight loss. So they start to lose weight, and then they start to have all these developing symptoms until the point that you get to stage 4, which we would call severe disease or AIDS. And you'll see that first symptom there would be HIV wasting syndrome. So that's when it gets advanced and they experience unintentional, significant weight loss, along with chronic weakness, diarrhea, and fever. And here's a numerical way to look at these categories. You'll see the CD4 T cell count category over here at the edge. And then at the third level of that is less than 200 per cubic millimeter. So you'll see these categories A, B, and C. So for category A, it's kind of looking back here, similar to these stages. Category A is asymptomatic, and the virus is slowly replicating. And we see that CD4 T helper cell count is greater than or equal to 500. It might even be around 1,000, it could be. Category B, we start to see those early symptoms. And then category C, you get to the advanced stage, the T cell count gets below 200. So how are people treated that are exposed or have full-blown HIV? Well, they have a few different drugs for this, actually. Now, let's say, before we talk about someone who has like full-blown HIV developed in their body, talk about, let's say someone just gets exposed to it. Well, the procedure, what they call, how they handle that is something called PEP, or post-exposure prophylaxis. And this would be a short-term treatment that you would give someone who just was exposed to HIV. So let's say they were pricked with a needle when working with someone who has HIV or AIDS, or they had unprotected sex with someone who they found out, the next day has HIV. Well, then what do you do? They call this post-exposure prophylaxis. And what they use is something called AZT. And AZT is a drug that keeps the viral particles from making copies of itself. So it gives the body time to clear the viral particles before it becomes a permanent infection in their body. So what that means is there is a major time constraint here. You have to get to these drugs really before 72 hours if you want them to be effective. And really, as soon as possible, the better. So if you were working with a patient and somehow, you were pricked with a needle that had pricked them, well, you would immediately start a combination of actually 3 drugs. But AZT or Zidovudine would be one of those drugs that you would see. So that would be the treatment. Now, when you get to someone like Magic Johnson, for example, so they've had full-blown HIV. It wasn't like a quick exposure and then they got immediate treatment. What do? They actually will use the same drugs that are used upon someone's initial exposure. They will take these AZT drugs and other combination drugs with them. And basically what it does is it's antiretroviral therapy, antiretroviral drugs that are used. And what that does is it prevents viruses that are retroviruses from reproducing and progressing. So it prevents the progression of HIV to AIDS because it keeps that viral load, how much of that virus is in their blood, so low that it's actually not even detectable. So it becomes undetectable. So by all measurable purposes, they don't really they have it, of course, it's still in their body, but it's not transmissible, actually. So it's undetectable and it's non-transmissible. Here's an interesting example. If you look at the NCLEX, when you start studying for that, this is just a question from there about this topic. And the question says, this is a study guide for it. It says a second-year nursing student has just suffered a needle stick while working with a patient that is positive for AIDS. Which of the following is the most important action that this nursing student should take? A, immediately see a social worker. B, start prophylactic AZT treatment. C, start prophylactic penamide treatment. Or D, seek counseling. And of course, the answer would be B. You would start AZTs. And that's going to keep that virus from reproducing in their body and allow their body to expel it. And they'll actually continue that with a drug combination for up to about a month. And that will prevent them from ever getting HIV. And definitely it will never progress to AIDS. If someone already has HIV, then they take these drugs and they'll actually be able to live a completely normal, healthy life, and it will never develop into full-blown AIDS. So what are some disease tracking terms as we finish up here? One of those is epidemiology, which would be the study of the occurrence, frequency, transmission, distribution, and control of a disease. So all of these topics surrounding a disease. So for occurrence, we have two terms that we use to describe the occurrence of a disease. One of them is incidence and the other is prevalence. So incidence would be looking at new cases, which can help you see what is the risk of getting this disease. If the new cases are very, very low, then it's not being spread. So the risk of developing the disease is very low as well. So it's an indicator of the risk of getting that disease in whatever region you're looking at. Prevalence, on the other hand, would be looking at the total number of cases. So you look at the old and the new. So this is analyzing the history and burden of that disease on a society. For example, I did a little research on HIV in America, for example. So in 2022, there were an estimated about 32,000 new HIV infections. So would that be incidence or prevalence? Well, this is the new cases of HIV that year, so that would be the incidence of HIV in 2022. Now, if I said there are 1.2 million people who lived with HIV in 2022, would that be incidence or prevalence? Well, because we're talking about the burden of that disease on the society in 2022, right? 1.2 million people were living with HIV, then that's the prevalence of HIV. Frequency would be how often the disease is occurring. So we have sporadic, where it occurs occasionally. Endemic, it's always there. Epidemic, many people get it in a very short time. And then a pandemic would be when it's a worldwide epidemic, right? With COVID-19, it would have started as an epidemic in China, but then it became a pandemic when it spread to the world and everybody was getting it really, really quickly. So the CDC, which is the Centers for Disease Control and Prevention, that would be a branch of the U.S. Public Health Service that would look at these values surrounding a disease. And they publish something called the MMWR, which is the Morbidity and Mortality Weekly Report, where they look at morbidity and mortality. Morbidity would be the incidence of specific notifiable diseases, and then mortality would be the number of deaths from a notifiable disease. And then a notifiable disease is just a disease that health professionals have to report on when they find it. So some examples of notifiable diseases would be things like measles, hepatitis, HIV, AIDS, salmonellosis, and tuberculosis. So nosocomial diseases, we talked about that previously in the last unit. That would be these hospital-acquired diseases. So these are avoided by practicing two types of isolation. So you have source isolation and reverse isolation. Source isolation would be you take the person who has that disease and you get them away from everybody else. So you isolate the person with the disease. Reverse isolation is when you have someone who would be susceptible to that disease and you isolate them so they do not get the disease. For example, when my brother was going through chemotherapy, he was reverse isolated. He was susceptible to diseases in a hospital, so he had to be isolated, and there are special protocols to prevent infection for him. So it could occur as a UTI from a surgical site, bacteria in the blood, respiratory, or in the skin. And then we talked about toxins that would be associated with these diseases before. We've already talked about these a few times. Remember the exotoxins? Those are produced inside the microbe and released. The endotoxins are a part of the microbe and are released when it dies. And that's it for this lecture.